I'm Dr. John Norian, and I am here. I'm just going right here. So a little bit about me is I'm a double board certified reproductive endocrinologist. Oh my gosh, that is such a mouthful. But I'm originally from Los Angeles. I am very much involved locally, where I have the ability to, teach residents, teach medical students, but I'm also involved nationally, and I'm involved in so many different groups. One are more the professional societies for IVF, which is called SART, or the Society for Assisted Reproductive Technologies. I'm, of course, a fellow of the American College of OBGYN. I'm very involved in the ASRM, and then also with more LGBT focused groups. So a big one is the Family Equality Council, and then another one is an organization called Men Having Babies, which supports men having babies. We give grants for fertility treatments and things like that. The CADE Foundation is another wonderful organization that helps people sort of walking the walk of fertility. They give grants, have education, really a good group. So just to talk a little bit more just about sort of some of the topics I hope to touch on today. So things that we can do to optimize our natural fertility. We'll talk a little bit about some of the testing that we can do. And then other features, selecting a donor, whether we're selecting a sperm donor, whether we're selecting an egg donor. Talk about our success rates. Talk about donor sperm versus IVF. If we're a single female or in a gay lesbian relationship. Also talking about advanced genetic testing, genetic screening, and then how to select a surrogate, and then the fun part, talking about how do we transfer this beautiful embryo that we've helped create into a perfectly sticky uterus. All right, so let's just talk a little bit about what can we do now to help our fertility. So I tell everyone that we work with to do their best. If you have eggs and you have a uterus, please take a prenatal vitamin. If you have testicles and male reproductive parts, please take a multivitamin. Do your best to eat a whole food diet. Eat real food. Oh my gosh. Try to avoid simple sugars. They're everywhere. Have more plant-based proteins. Some meat is definitely okay. Do your best to avoid toxins. If you smoke, stop. Try to keep alcohol at a minimum or avoid it, especially during advanced care. With fertility, we don't want people being too thin or too heavy. So optimal weights tend to be a BMI between 20 and 25. And then also, I know that many of you are what I would say fertile, meaning that you haven't necessarily struggled with infertility, but still walking the walk of fertility treatments can be a little hectic, and lean on the ones you love. Sometimes our parents, our family can be really hurtful, and they can say things that are a little bit upsetting. So sometimes working with a therapist, sometimes working with a counselor, a priest, a rabbi, they also can help give guidance as we go through the fertility process. All right, so what do we need to get pregnant? So we need sperm here, we need eggs, and then we need the anatomy. And guys, we do a variety of things to screen different organs of our reproductive structures, excuse me. So for men, we typically will do a semen analysis. That's always the first step to evaluate male reproductive health. For women, we start trying to understand, are they ovulating, are they not? What are some ways where we can check the eggs and check the ovaries? And then we also want to check the uterus. We want to check, are there fibroids, are there polyps, are the tubes open? So we have different tools that we can use to screen different key components. So with the men, like I mentioned, we do a sperm analysis. It's an advanced test. We check the concentration, the movement or the motility, and the morphology or the shape of the sperm. At HRC Fertility, we have 9 offices. They're all accredited. We're contracted with Quest, with LabCorp. I work in 2 main offices, so I cover Los Angeles County. I have an office in Pasadena, and then we also have an office here more in our Inland Valley, in the Inland Empire area in Rancho Cucamonga, which is wonderful because we take care of a broad catchment area of people. In terms of other stuff, actually, let me just go back to the male. Sometimes, believe it or not, men can also contribute to miscarriage. We don't think about that typically, but if the sperm is highly fragmented, if the DNA is highly fragmented, that may also play a role in our fertility and increase the likelihood of miscarriage. It's another reason why many times I do recommend that people take antioxidants, so things like vitamin C, CoQ10. We also talked about taking vitamins and eating healthy. Okay, so now for women, we're looking at, or people I should say, with a uterus, because remember, we take care of people of all different genders, people who are cisgender, people who are transgender. So, the terminology, words matter. Don't tell our president, but of course, words do matter. So uterine evaluations start with typically in hysterosalpingogram. So this is what I call a dye test. This is where we go to a radiology center and we can screen the uterus. Right here is a more typical one in the lower left, where you can see a nice normal uterus and these delicate open fallopian tubes that are spilling open. Here, this woman or this person has dilated swollen tubes. It's what we call hydrosalpinges. That's a big, complicated medical word for a dilated, closed, swollen tube. And that may be a result of a few different things. So a person who has had pelvic surgery, like a ruptured appendix, or maybe really bad endometriosis, or maybe there's an infective cause, a history of gonorrhea, chlamydia, PID, pelvic inflammatory disease. Those are other reasons. In the lower right is something called fibroids. So these are these tumors, fibrous balls of tumor that can push in on the uterus that can disrupt the embryo from implanting. So it's really good for someone like me to know about before starting treatment what we're working with as far as the uterus goes. And then rarely people can have a bicornuate uterus or a uterine anomaly. Now, I always will do an ultrasound on people who have typically female reproductive parts. And the reason is we're looking for fibroids, these fibrous balls of tumors. If you're ever bored, guys, please go on Google Scholar or PubMed and put in my name. And back in the day, we did a lot of basic science research looking at these tumors. Polyps are benign little growths that can disrupt an embryo from implanting or cause irregular bleeding, irregular periods. We also check out the ovaries. We look for cysts on the ovaries, so things like endometriomas or benign cysts that typically are not that big a deal, but it's good to know about before treatment. Now, a big part of a fertility assessment is checking a woman's ovarian reserve, or sort of quote unquote, how many eggs do I have, Dr. Norian? How well are my ovaries working? So the first step is always doing an ultrasound. So you can see here, these little black spots, these are where the eggs live. They're called follicles. So ideally, just Jane Doe, American, European, Asian person of the world will have greater than 12 resting follicles on both ovaries combined. Now, a woman who has less than 5 follicles, that's a whole different thing. And that's telling me originally that her ovaries may be a little bit sleepy. It also helps me because it helps me determine how much medication to give a person when we're starting treatment. It also helps tailor which type of treatment may be best for that person. Now, other ways where we can check ovarian function is by doing a quick blood test. So many times we call this as part of a fertility checkup. And this is where a doctor like myself will order an AMH level, an anti-Müllerian hormone level. And for the general population, I typically want that number to be greater than 1.5. Now, when I'm working with single men or men in a gay relationship, we want that number for our egg donors to potentially be even higher, to be greater than 2.5 ideally. And I'll talk to you about why or why not in just a few minutes. Other tests that are sometimes done are an FSH and an estrogen level. And FSH levels, we want that to be ideally under 8. When it's over 12, that starts making me a little bit cautious, and it also gives me more information as your reproductive specialist. Now, you might see here on the side of this slide is egg quality. So egg quality is really something that's not measurable. The big deal with egg quality is female age. Now remember, as time goes on, all of our fertility will change. And this happens whether you've had a child before or whether you haven't. And this typically happens somewhere around the age of 35-ish. And I'll talk a little more about that in just a few minutes. So now I want to just talk a little bit about genetics. So before we start treatment, we usually recommend to most everyone to get a simple genetic test done. And what this is a simple blood test where we can make sure that a person doesn't carry a silent or recessive mutation. Remember, being human, we all carry disease. Simple tests that are very cost effective. Typically, we can screen for over 200 plus conditions. Right now, I think I'm screening for a panel that screens for over 297 genetic mutations. Oh my gosh. These are things like cystic fibrosis, sickle cell disease, all sorts of thalassemias, Tay-Sachs, all sorts of rare inherited diseases. Sometimes they can also be sex-linked on the X or Y chromosome. So that's more reason why we should screen both the egg source and the sperm source. And prior to pregnancy is an ideal time to do this. It's also why I tell people, seriously but jokingly, why we don't marry our brothers and sisters. You know, remember, we all carry silent disease. So, all right. So egg freezing. So let me just talk a little bit about what can we do before we transition, right? So if we're going from female to male, if we're going from male to female, or God forbid we get breast cancer and we need, or testicular cancer, and we need to preserve our fertility. So in 2008, 2009, there was a big advancement in technology where we learned how to vitrify, or what I would say snap freeze, the eggs. With that technique, we are able to thaw them very reliably and fertilize them with very similar success rates to fresh eggs. It's even at the point now where we can even use egg banks, not just sperm banks or cryobanks, but egg banks to help to add to a person's fertility or family. It appears to be a very safe technology, and the ideal time is debated, but typically we want that to be younger than older. Now, before people transition, so taking testosterone, taking different therapies to sort of meet the gender of your choice, of your preference, testosterone will definitely silence the ovaries and will make it so you don't ovulate and make treatment for fertility very, very difficult. Now, removing testosterone, oftentimes the ovaries recover, but sometimes they don't. They don't do it as well. It depends how long you are on the testosterone therapy and how much you are getting. Now, in terms of sperm freezing, we've been freezing and thawing sperm for decades. Um, Gosh, even reproductive biologists can extract sperm from like glaciers and things like that, from, I don't know, prehistoric humans. But we use specialized cryoprotective agents. Again, fertilization rates are very reliable. This is where I can help men who live in Europe, who live in Asia, who live in New York, come to Los Angeles, come to Pasadena, give a deposit, freeze it very reliably, and I can say with confidence that we should have a really high fertilization rate and success rate. So freezing and thawing sperm is a very reasonable technology. Also, men with testicular cancer. I know Lance Armstrong is a very sort of controversial figure, but you know the most common reason why men with testicular cancer don't freeze sperm? It's because their darn doctor didn't tell them. Oh my gosh, like all guys need is, dirty magazines or a video and a cryobank, and they're good. Where people with ovaries, it's a little more of a process to retrieve their eggs and freeze them. But again, the technology works. It's very reasonable. So okay, so now what are some things that I'd like you to think about when we're selecting a donor, whether it's an egg donor or whether it's a sperm donor? So for egg donors, we typically recommend that the age of the donor is going to be a woman who's in her 20s. We want her to be healthy. We want her family history to be healthy. Remember, it's okay if the grandparents of an egg or sperm donor had a little bit of blood pressure, a little bit of diabetes. That's perfectly okay. We just don't want them to have rare inherited genetic disorders. We don't want, let's say, early heart attacks, early strokes, or things that may be present in your own family. So we want to try to avoid some of that type of stuff. Now, other stuff, so personal traits, so hair color, eye color, height, weight. These are things that are very much your decision. For egg donors, they are extremely kind women. They will write essays. They describe themselves. Are they more artistic? Are they more mathematical? What's their favorite movie, favorite book? Sperm donors, sometimes you get that information, but maybe not to the same degree. Also, you'll see when we go through the process, there's even more screening that goes into it. Believe it or not, with egg donors, sometimes you can even meet them, whether it's on Skype or WeChat or WhatsApp, or even meet them for coffee. Remember, they don't want anything to do with the parenting or the pregnancy. They really just want to help someone and potentially help pay for some of their education. But again, very reasonable thing. None of us are totally anonymous anymore. I guess that's what I was trying to bring up. That this idea of a totally anonymous egg or sperm donor doesn't really exist anymore because of 23andMe, because of Ancestry.com. These are things that facial recognition software. So this idea of trying to pretend that someone is totally anonymous doesn't totally make sense. So usually there's different methods to meet the donor potentially in the future if that's something you wanted, and things like that. So now what I wanted to talk about a little bit more is this whole process. Remember that all this is regulated, guys, by the FDA. It's regulated by our federal government. So we do medical clearance. That's where I really come in. So we're doing full histories, full examinations, infectious disease screenings, FDA labs. So we're screening the donor for HIV, hepatitis, syphilis, all sorts of stuff. We also do, of course, ovarian testing. And then the genetic screening. Remember, sperm and egg donors will have had at least a basic genetic panel. Typically, I try to recommend that they've had a larger panel if possible. And then psychological screening. We want to make sure they're doing this for the right reasons. We want to make sure they're not being coerced. Make sure they're not bonkers. and that sort of thing, where they meet with a licensed professional. And then, of course, legal. These become your eggs. These become your sperm for basically infinity and beyond. Um, Basically, if there's embryos that remain at the end, they may want to know if what you're going to do with them, if you're going to transfer them to someone else or whatnot. So there's this idea of disposition of embryos. Sometimes that's where the lawyers sort of come in. Okay, so now let's talk a little bit more about selecting egg donors. So for the many gay men that I work with, I want to help them select an ideal donor. So things that we do is we always start with the follicle count. So remember here, you can see on the slide these little black spots, how this ovary looks almost like a chocolate chip cookie. So the chips are where the eggs live. And especially if we have two sperm sources. So let's say we have, future dad one, future dad two. We'd ideally like to have biological children from both sperm sources. We want more eggs to work with from the beginning. So typically, we want to get at least 15 to 18 resting follicles. Sort of my optimal number of eggs in this situation is going to be 20 to 30 eggs. And I'll talk to you about why that is in just a few minutes. AMH levels for donors, egg donors, we usually like that to be greater than 2.5. There's different egg donor agencies that we work with. Some of the surrogacy agencies that we work with have their own egg donor programs. Myself and my partner are setting up an egg donor agency called Synergy, but they're all going to be pre-screened donors and high quality donors. So me as your physician, I'm super OCD and strict, and it's my job to get you pregnant. So I need to help you choose a good donor because that's a big part of the puzzle. Okay, so we've talked about screening. We've talked about some things we can do to optimize our fertility beforehand. We talked a little bit about some genetic tests. So we talked about choosing donors. So let's talk about success rates. So, okay, some of these success rates come involved with people who have infertility. Now remember, you guys don't necessarily have infertility. You just haven't adequately exposed an egg with your sperm, or you haven't been exposed with sperm by, if your egg has not been exposed to sperm. So, ideally, you're going to be more fertile than some of my other patients who've really struggled with fertility issues for, many, many years. So that being said, typical fertility in people having a heterosexual relationship is going to be about 20 to 25% per month. That's sort of normal Jane Doe, John Doe American fertility for couples in 25 to 30-year-old range. So then, let's say we're doing donor sperm IUIs, our pregnancy rates are going to be 10 to say 15% per cycle doing donor sperm IUIs. Now, if we did donor sperm IVF, we're going to have higher pregnancy rates. And if we did egg donor IVF, the pregnancy rates are going to be 60 to 80%, even higher, being that we have screened the embryos with an advanced chromosome test. So that's a little bit of a ballpark. One other huge thing to mention is, oh my gosh, thank goodness for IVF. Over 7 million, 8 million children have been born as a result of IVF. They won the Nobel Prize for it in 2012. It's a very reasonable, safe technology that we keep on incrementally improving. So live birth rates per transfer. This is the national data. So like I mentioned before, all women's fertility will decline around the ages of 33, 34, 35. And this happens because as time goes on, our egg and embryo quality will decline. So I'm not sure you guys can see my cursor, but you can see in this range how our fertility will start to decline. Now, please understand, I definitely have pregnancies in people who are 40, 41, 42. I've even worked with the sibling of one of my future gay dads, so the sister of one of my future gay dads, and used her eggs when she was 39, 40 and helped them conceive with the partner sperm and then the egg of the sister-in-law. So this is definitely something that we do, and I'm really proud of it. So in terms of other stuff, so let's talk a little bit about should I do donor sperm IUI, or should we think about doing donor sperm IVF or reciprocal IVF? So let me just talk a little bit about donor sperm IUI. So there's definitely some benefits, right? The way donor sperm IUI works is that we more gently stimulate the ovaries. We give medications like Clomid, letrozole. I do ultrasounds to monitor you to make sure that the follicles, those little black spots, to make sure that they're responding well. And then we help trigger ovulation. And then we precisely thaw and inseminate the sperm directly into the uterus. I typically, when I do donor sperm IUIs, I typically will do 2 IUIs. And I do that, I time it just right based on the trigger shot. We time the IUIs so that we have sperm on board prior to the egg dropping. And that's where we really can maximize pregnancy rates. So that's that. One other thing I didn't talk about regarding IUI, selecting a sperm donor is in our country, there's about 15 cryobanks or sperm banks. We'll give you names of, say, 4 or 5 of them. And then usually you get the passwords and you can sort of screen them. It's great if you screen them with your partner. You guys sort of talk about, like, what are some things we want in a donor? And then usually you go your separate ways. There may be a glass of wine involved or whatnot. And then you come back and you share notes. And you're like, these are my top 3. These are your top 3. And oftentimes that helps sort of strengthen your relationship. And believe it or not, that's oftentimes how gay men that we work with, how they will help select donors. Because they'll get the profiles for the egg donor agencies and sort of get their top, few that they're excited about. And then they'll share notes and things like that. So, okay, so donor sperm IUI, pros are there's a little less monitoring, there's lower cost, fertilization does occur inside your body. Problem is success rates are 10, 12, 15% per cycle. After 3 cycles, typically about 30 to 35% of people will be pregnant. And also remember that donor sperm can be a little bit expensive, and it's also still a little hectic just coming into the office. But again, it's something we do, it's something I'm proud of, and it's oftentimes a good way to start. In terms of reciprocal IVF, this is really neat because what we can do, let's say we have 2 gay moms, is we can use the egg from mom 1 or mom A, and then we can use the uterus from mom B. And I've even done this in couples before one of the partners has transitioned, which is so cool because we can get his eggs, before he transitions and have them on ice or fertilize them, however we want to do it, create embryos. And then his wife will then get pregnant with his eggs, which is so cool. So success rates are higher. They vary between 50 to 80%. Big factors are going to be the age of the egg source. It also depends if we do the PGTA testing, the chromosome testing. And that's where we have the chromosomes, the DNA from one future parent, but also a genetic influence from the other future parent. So again, really neat that we could even do this. Science matters. If you guys follow me on social media, a lot of times I'll hashtag science matters. Uh, it's really cool, the technology that's out there. So, okay, so what about IVF? How the heck does this all work? So the way it works is we give medications to help mature and grow the black spots, mature and grow the follicles. We do this for about 9, 10, 11 days, very mild, medications just underneath the skin, sort of like a diabetic person taking insulin. We monitor you closely, make sure you don't over-respond, or make sure the egg donor doesn't over-respond. Then we have a simple procedure where we retrieve the fluid from the follicles. We retrieve the eggs very precisely. The person's taking a nap for about 10, 15 minutes, very light twilight anesthetic, general anesthetic. And then once we get the eggs, we have two different options how we fertilize them. So we either can put the egg around a droplet of sperm and we let the best sperm win. It's very Darwinian. Or we fertilize the egg using a technique called ICSI, where we identify the best looking, best moving sperm, and we help it out. We inseminate a single sperm into the egg as a way to help improve fertilization. Now, going from the egg all the way to the embryo, not all the eggs that we retrieve are going to be mature. And then not all the mature eggs will fertilize normally. So let's say we got 20 to 25 eggs. So on average, 16 to 20 of them would be mature. And then say 12 to 15 would fertilize normally. Now, of these fertilized eggs, not all of them will grow and develop. Now, here's a little video. I love this video. So this is what we all look like when we were dividing. So that's the embryo here, 8 cells on day 3. And then on day 4, it's amazing, the embryo compacts. And this is the exciting bit, guys, where the embryo expands. And right here, I'm not sure you guys can see my cursor. This is where, this is where the baby portion is, the portion that will develop into the future fetus or human. Oh my gosh. And then over here is the portion that will develop into the placenta to the right. You can see how the cells look like a cobblestone street. Those cobbles are, those cobbles are the cells that will develop into the placenta. And that's what we all look like before we implant it into our mom's uterus. So, okay, what about this PGS, PGT? What the heck is this? Maybe you've heard about it from a friend or family member. What this is a technique where we can biopsy the outside of the embryo. You can see just behind. Here's a picture of that embryo that has about 120 cells. And we get 4 or 5 cells, and then we can do testing on it. And we can make sure, number one, that it's chromosomally normal. We also can tell with very high accuracy if it's chromosomally male or chromosomally female. So it's what we call sex selection. We get more information about the embryo. It also makes doctors like me feel more comfortable just implanting a single embryo and still maintaining a very high implantation rate, pregnancy rate. Other indications are as we get older, our egg and embryo quality decline, and this is another way for us to avoid implanting an embryo with the wrong number of chromosomes. Something like Down syndrome, Turner syndrome. Oh my gosh, that's the last thing we want to do. So now, how do we select a surrogate? So what we do is we always do medical clearance. So I do a full history. We make sure her pregnancies were straightforward, ideally vaginal deliveries. We don't want there to be more than 2 C-sections that can make for a difficult transfer or mucus or all sorts of things. And we don't want her to be obese. We want her BMI to be less than 30. We, of course, will screen her for other conditions. We do full laboratory panel, checking her thyroid levels, her glucose level, cholesterol panel. And we, of course, check her uterus. We want to have an ideal uterus to glide the embryo into, so that we can really, really optimize our pregnancy and implantation rates. Of course, again, like egg donor clearance, there's psychological screening, legal clearance that ensures safety for you and potentially your partner, your child, and also safety for the surrogate herself. Of course, we do an ultrasound on the surrogate to make sure her uterus is good. And then here, look at this video. This is where we glide the embryo into the uterus. You can see the lining is nicely thickened. And we potentially will film videos. We'll also have the future parents in the room. And we're typically listening to spa music. And right there, I'm not sure if you saw right there, that little white spot. That's where the embryo is, and that little fluid droplet. Then we talk to the embryo. We tell it to behave, to stick, to be a good child, do your homework, all sorts of things. And then in terms of success rates, especially when we're working with egg donors and surrogates, our success rates are high. We have pregnancy implantation rates anywhere from 65 to 80, 85%. It's something that I am so proud of, and it really has to do with doctors like myself screening the donor, making sure she's an excellent donor, screening the surrogate, really being strict, trying to get the best of the best. And these are just some pics from recent graduations. Graduation day is always an exciting day in our office. I monitor the pregnancy until about 10 weeks. We do ultrasounds, we adjust hormone levels, and then we graduate the patient to their OB around 10, 11 weeks. In terms of other stuff, why HRC? Why Dr. John Norian? HRC, we are founded over 30 years ago. We're a large practice, but with really intimate, individualized, personalized care. I do 98, 99% of my own retrievals, 98, 99% of my own transfers. I am so proud of our success rates. That's really what drives us. We have state-of-the-art embryology lab. Like I mentioned, I go in between our Pasadena office and our Rancho office. And I'm, of course, double board certified and participate in many, many different components of reproductive health. We have in-house laboratory. I think I might have skipped that, but the PGTA testing is, we have an in-house, highly advanced reproductive genetics laboratory. We have an ideal locations. I myself would love to be the one sort of guiding you through the process. We have a wonderful team of nurses, coordinators, and embryologists, and we're close to many egg donors, many surrogates. This also helps decrease costs. We're also part of a heart program, which helps our patients with HIV have children without the virus. Oh my gosh, isn't that so cool? Science matters. So we, useful links, again, ASRM, American Society of Reproductive Medicine, has much good information. Our website is a good resource also. Family Equality Council does a lot of advocacy for our LGBT patients, and Cade Foundation grants, and Fertile Hope Livestrong for patients with cancer. And then myself, I give my cell phone number literally to all my patients. I'm highly involved. Oftentimes the cell is only for emergencies. And then please, please feel free to follow my professional pages on social media. I know it's silly, guys, but we try to post interesting videos and educational, posts and things like that. So I hope this helped a little bit. And I would love to answer any questions that you may have. I know that these webinars sometimes are fun because we can get different questions and things like that. So I hope that was useful, and great speaking with you.